Hello everyone in CardioMinds channel and welcome to the 6th video in the guidelines of acute coronary syndromes, and today we are discussing the complications of acute coronary syndrome. In our video today we are going to discuss the heart failure, which is a very common complication of acute coronary syndrome, the mechanical complications, LV thrombus, which is very common to be found in STEMI patients, post-acute coronary syndrome pericarditis, atrial fibrillation, ventricular arrhythmias and their mortality risk, bradyarrhythmias, which are very common in inferior STEMI, and the bleeding events. Let's start with the heart failure, elaborating some facts. Acute heart failure is a common complication that may complicate acute coronary syndrome, significantly increasing the risk of the in-hospital complications. For example, acute kidney injury due to reduced renal blood flow, pneumonia due to the pulmonary venous congestion, respiratory failures that may complicate acute pulmonary edema, and of course these may result in death. A common situation for acute heart failure to be de novo complicating acute coronary syndrome, and this should be distinguished from pre-existing heart failure exacerbated by acute coronary syndrome. The management is different, and of course the prognosis is different, and the recovery of LV function is more expected in the de novo acute heart failure rather than the pre-existing one. The problem that acute heart failure may impede the straightforward diagnosis of acute coronary syndrome because the patient is having chest pain, but this is predominated by the dyspnea and orthopnea and sometimes acute pulmonary edema. So if you didn't take meticulous history and you didn't notice the dynamic ECG changes or the markers elevated in the serum, in this case you may miss a diagnosis of acute coronary syndrome and you are only focusing on the management of acute heart failure. And in some clinical scenarios, the increased troponin level may be the result of the acute heart failure per se, due to the myocardial injury caused by heart failure, rather than myocardial necrosis due to ischemia. But of course, if there is a detectable rise or fall in the cardiac biomarkers, in this case this raises a suspicion of acute MI according to the fourth universal definition. So what will be the action in this case? Of course, those patients need coordinated management of both conditions. Assessment by echo is mandatory to assess the LV function, RV function, both dimensions, resting segmental motion abnormality, and if there is a possibility of mechanical complications as a cause of acute heart failure. Immediate coronary angiography and PCI of the infarct-related artery is essential, and this is a primary line of treatment because here there is a reversible cause, which is ischemia, and if it is adequately treated, in this case the heart failure may resolve. Managing acute heart failure, of course, according to the ESC guidelines by using diuretics, vasodilators, inotropes or vasopressors according to the clinical status of the patient, whether he is dry or wet, whether he is cold or warm. And mechanical circulatory support may be considered in selected cases like the ECMO or the intra-aortic balloon pump, and we are going to discuss this later. And some patients may need invasive respiratory support like mechanical ventilation, either invasive or non-invasive in some cases, and renal replacement therapy like hemodialysis may be needed in case of acute kidney injury. So what are the recommendations for acute heart failure and cardiogenic shock? There are no specific recommendations for the heart failure per se, but we have the specific recommendations for cardiogenic shock that we discussed in the previous video. Immediate coronary angiography and PCI of the infarct-related artery, if indicated, is recommended as a class 1 in any patient with cardiogenic shock complicating acute coronary syndrome like STEMI, class 4 needing primary PCI, or non-ST elevation acute coronary syndrome with hemodynamic instability needing immediate invasive strategy. Emergency CABG is recommended as a class 1 if the PCI is not feasible or unsuccessful, and in some cases if there is evidence of mechanical complications causing the hemodynamic instability, emergency surgical repair or catheter-based repair is recommended based on the heart team discussion. In some patients, primary PCI strategy is not available within 120 minutes, meaning 2 hours, from the time of STEMI diagnosis. So in this case, fibrinolysis should be considered as a class 2A, provided that mechanical complications have been excluded. Of course, the success rate of fibrinolysis is less than that of the primary PCI in STEMI class 4, but in some cases this is the only solution, because as we know, if timely PCI cannot be performed in patients with a working diagnosis of STEMI, so fibrinolytic therapy is recommended within 12 hours of the symptom onset in patients without contraindication to fibrinolysis. Intra-aortic balloon should be considered as a class 2A in those with mechanical complications causing hemodynamic instability, because here it decreases the systemic vascular resistance and the afterload, so reducing the shunt fraction in case of ventricular septal rupture and reducing the regurgitant fraction in case of acute mitral regurgitation. The short-term mechanical circulatory support like ECMO, for example, has just a class 2B in patients with acute coronary syndrome and severe or refractory cardiogenic shock. Because as we remember from the last video, the ECMO CS trial that showed that the immediate use of VA ECMO in patients with rapidly deteriorating or severe cardiogenic shock did not improve the clinical outcomes compared with an early conservative strategy that permitted the downstream use of ECMO in case of worsening hemodynamic status. This explains why so far short-term mechanical circulatory support has just a class 2B. And the big knows that the routine use of the intra-aortic balloon pump in acute coronary syndrome patients with cardiogenic shock but without mechanical complications is not recommended. This is a class 3. As we remember, the intra-aortic balloon pump shock 2 trial showed that its use did not significantly reduce the 30-day mortality in those with cardiogenic shock complicating MI. So the maximal benefit for the intra-aortic balloon is in those with mechanical complications. By the way, let's now discuss the mechanical complications. They usually occur in the first 7 days following MI, most commonly in those with STEMI. Their incidence, of course, has dropped significantly in the primary PCI era, as a large epidemiological study including 9 million acute coronary syndrome patients showed the prevalence of mechanical complications in STEMI patients as 0.27%, with the in-hospital mortality about 42.4%, while in non-STEMI it has much lower incidence rate with 0.06%, with lower in-hospital mortality just 18%. And this of course makes sense, because in STEMI there is transmural necrosis, so the incidence of mechanical complication is much more common in STEMI rather than non-STEMI. And there are some red flags that raise suspicion of mechanical complication if you find one of them in the patient. For example, presence of a pulmonary congestion or jugular vein distension. In some cases, the patient may develop acute pulmonary edema, which is common, of course, in those with acute mitral regurgitation. Sudden hypotension should raise suspicion of mechanical complication, and the recurrence of chest pain also may suggest re-infarction, and so you need to exclude mechanical complication. Presence of new cardiac murmurs suggests, of course, presence of acute mitral regurgitation or ventricular septal rupture. So whenever you find systolic murmur, you should suspect mechanical complication. In all these situations, you should have an immediate echo assessment in order to confirm or exclude mechanical complications. This table compares the 3 common mechanical complications, which are the ventricular septal rupture, papillary muscle rupture, free wall rupture regarding the onset, clinical presentation, the diagnosis and workup, management strategy, role of surgery, and role of mechanical circulatory support as a bridge to decision or surgery, when to adopt non-surgical treatment like percutaneous treatment, and the role of palliative care in some patients. A common dilemma whether to use mechanical circulatory support or intra-aortic balloon pump in those with mechanical complications. So far, the temporary mechanical circulatory support can be used to improve preoperative hemodynamics or just prophylactically. But the problem is that this approach requires more data and evidence in order to validate its clinical benefit. Moreover, sometimes the mechanical circulatory support in case of VSR may increase the left-to-right shunt or reverse the direction of blood flow, resulting in a right-to-left shunt with oxygen desaturation. This depends on the type of the device and the extent of circulatory support. That's why sometimes it may be dangerous. Therefore, so far patients with mechanical complications should be considered for intra-aortic balloon pump while awaiting surgery. And the common question whether to adopt surgery or percutaneous treatment. Of course, surgery is the first line, as here the patients with acute coronary syndrome and mechanical complications should be scheduled for surgical repair. Like, for example, patients with VSR should have interventricular patch application, the same principle that is adopted in children with VSD having surgical correction. Complete papillary muscle rupture should have mitral valve replacement, while partial rupture should have mitral valve repair and papillary muscle reconstruction. And free wall rupture, which is a very dangerous complication with early death, should have immediate surgery. In some patients who may have a high risk for surgery or a contraindication, percutaneous intervention may be adopted. For example, VSR scheduled for intraseptal closure device, patients with papillary muscle rupture, mostly partial rupture, having edge-to-edge mitral valve repair, and free wall rupture is very difficult to be treated by transventricular closure. It is extremely difficult procedure with risk of deterioration and sudden cardiac arrest. That's why free wall rupture we usually adopt surgery. So who will decide whether the patient should be scheduled for surgery or percutaneous treatment? A multidisciplinary approach adopted by the heart team discussion can decide the management of those patient regarding the type and the time of intervention, whether it is surgical or percutaneous, use of mechanical circulatory support or intra-aortic balloon pump, the risk of surgery, and when to decide for palliative care in some cases in which the treatment or the repair of the mechanical complication is extremely difficult. Let's now move to a common complication but still dangerous. The LV thrombus has declined regarding the incidence in the primary PCI era, but still relatively common, especially following anterior STEMI, where it can be present in more than 9% of patients according to a large meta-analysis. It may also occur in those with inferior STEMI, as they may develop akinesia or aneurysmal dilatation in the inferior wall, resulting in an LV thrombus, or in those with non-STEMI, but much less common than anterior STEMI. Echocardiography is still the first-line imaging test to detect LV thrombus, but in some cases echo may not be sufficient, so we may adopt CMR or contrast echo. The identification of LV thrombus has been reported to increase in the first 2 weeks post-MI, but in some patients after discharge, LV thrombi may develop. This indicates that maybe delayed imaging after 2 weeks in high-risk patients, for example, those with extensive anterior STEMI with severely impaired LV function, may be of value. But so far, much data is needed and evidence in order to validate this practice. So what are the recommendations regarding LV thrombus? As we know, echo is the first-line imaging test, but CMR should be considered in case of equivocal echo as a class 2A, or in cases of high clinical suspicion of LV thrombus with negative echo for thrombi. As a contemporary CMR data reported that the LV thrombus is present in up to 6.3% of STEMI patients and 12.2% of those with anterior STEMI. This suggests that the incidence of LV thrombi may be underestimated with echo. And in some cases, if CMR is not available, we can use the contrast echo to detect a filling defect in the LV cavity, indicating presence of an LV thrombus if it is not well visualized on echo. And the famous recommendations that I think most of you know, that it was released recently regarding the oral anticoagulant, that you can use vitamin K antagonist, which is a classic treatment for LV thrombi, or non-vitamin K oral anticoagulant. It can be used and should be considered for 3 to 6 months in patients with confirmed LV thrombus. So NOACs are no longer an off-label use in those with LV thrombi, and this should be guided by repeated echo or CMR to consider the bleeding risk and the embolic risk and the need for concomitant antiplatelets, because as we know, those patients will take antiplatelet and anticoagulants. So here the triple antithrombotic therapy should be adjusted according to the ischemic risk and the bleeding risk, as we mentioned in the video of treatment of acute coronary syndrome. And so the choice of therapy should be tailored according to the patient's clinical status and the results of follow-up investigations. And take care that omitting oral anticoagulation in those patients increase the risk for embolic stroke, increase the risk for other embolic complications like acute lower limb ischemia or mesenteric vascular occlusion. Let's now move to the post-acute coronary syndrome pericarditis. Of course, it is much more common to occur following myocardial infarction rather than unstable angina, because the trigger here is the necrosis of the cardiac muscle fiber. It may be either early post-MI pericarditis or late, which is called Dressler syndrome. So what is the pathophysiology for both of them? In the early post-MI, it develops within 4 days after the onset due to the transmural necrosis causing inflammation of the visceral pericardium, while in the Dressler syndrome, which is called late pericarditis or sometimes post-cardiac injury syndrome, because it may occur after MI, after cardiac trauma, or after cardiac surgery. Of course, it is infrequent in the primary PCI era, but it mostly occurs with late or failed reperfusion or large MI size, occurring 1 to 2 weeks following the onset of MI due to hypersensitivity reaction in genetically predisposed individuals due to the release of cardiac antigens. So how to diagnose post-MI pericarditis? It is the same criteria that were mentioned in the guidelines of pericardial disease. 2 or more of the following criteria, like pleuritic chest pain, pericardial friction drop, ECG changes suggestive of pericarditis, and new or worsening pericardial effusion. Either 2 or more of them, you can diagnose acute pericarditis after MI. And according to the onset of symptoms, you can determine what is the subtype. In both types, inflammatory markers like CRP and white blood cell increase in more than 80% of cases. Cardiac troponin may increase due to epicardial involvement, and echocardiography may show pericardial effusion in some cases, but CMR may be essential as it can show the pericardial inflammation and it can confirm or exclude the possibility of subacute myocardial rupture, which is sometimes called contained rupture in those with significant pericardial effusion more than 10 mm post-MI, because this subacute rupture can turn into free wall rupture resulting in mortality. So how to treat those types? In early post-MI pericarditis is usually self-limiting, but the treatment here can include aspirin 500 mg, which is a large dose, every 8 or every 12 hours for maximum 5 to 7 days, as prolonged treatment beyond 1 week is usually not required. Take care that the large dose of aspirin here may lose the antiplatelet effect, so the P2Y12 inhibitor here is mandatory. And regarding Dressler syndrome, the first line therapy includes also aspirin, but with a larger dose from 500 to 1000 mg every 6 or every 8 hours until symptomatic improvement, and then we taper the dose by 250 to 500 mg every 2 weeks, and we can add colchicine 0.5 mg twice per day as an adjunct for 3 months, so the duration of treatment here is longer and including 2 medications. Although we know that pericarditis is usually associated with a larger infarct size or poorly revascularized, but so far there is no evidence that it has an independent prognostic significance. So pericarditis per se does not increase or worsen the prognosis, but it is usually associated with larger MI size or late revascularized MI, which itself may worsen the prognosis. And in case that the patient has an indication for oral anticoagulation like LV thrombus or AF in patients with post-MI pericarditis with or without pericardial effusion, it is safe to start anticoagulation. Don't be afraid of hemorrhagic effusion, because here the embolic risk from the LV thrombus or AF is higher than the bleeding risk, and you can have follow-up echo to exclude hemorrhagic effusion. Let's now move to a famous arrhythmia that develops with acute coronary syndrome. Atrial fibrillation is the most frequent supraventricular arrhythmia in those with acute coronary syndrome, either pre-existing and first time detected or sometimes new onset. Regarding its prognosis, those with AF usually have more comorbidities like hypertension, diabetes, CKD, COPD compared with those without. That's why those with AF are at higher risk of complications. But regardless the complication, patients with acute coronary syndrome with documented AF of any length have worse short-term and long-term prognosis compared with those in sinus rhythm throughout their hospital stay, because atrial fibrillation itself worsens the prognosis and increases the risk of embolic stroke. Besides, usually the occurrence of atrial fibrillation denotes larger infarct size in the LV, increasing the LV end diastolic pressure and so increasing the left atrial pressure, developing atrial fibrillation in those with a substrate, and sometimes it may be due to atrial infarction itself. That's why atrial fibrillation worsens the prognosis. In most cases, AF is well tolerated and no specific treatment is required apart from anticoagulation, of course, but in some cases it may result in hemodynamic instability, especially in those with severe LV systolic dysfunction. So in this case, DC cardioversion is essential. So what are the recommendations for AF? IV beta blockers are recommended when rate control is needed in absence of acute heart failure and absence of hypotension. And IV amiodarone is also recommended for rate control in case that the patient has acute heart failure. So you cannot use IV beta blockers, but you can use amiodarone, but in absence of hypotension, because as we know that IV amiodarone may result in blood pressure drop. Immediate electrical cardioversion is recommended in those with acute coronary syndrome and hemodynamic instability if AF is the direct cause of the hemodynamic instability, and in case of adequate rate control cannot be achieved with pharmacological agents. Some cases you may need intravenous amiodarone to facilitate electrical cardioversion before the DC shock or after DC shock to decrease the risk of early recurrence of AF in unstable patients with recent onset AF. But take care to monitor the blood pressure and heart rate during the amiodarone infusion. An important recommendation that a patient with documented de novo AF during the acute phase of acute coronary syndrome, long-term oral anticoagulation is essential after considering the CHA2DS2-VASc score and putting in consideration the Haspelet score. And it makes sense that a patient with acute coronary syndrome and documented coronary artery disease in the angiography, the CHA2DS2-VASc score would be at least 1. And if he is having more comorbidities like hypertension, diabetes, old age, cardiomyopathy or LV dysfunction, in this case the score would be higher. So this patient will need anticoagulation, preferred to be NOACs besides a concomitant antiplatelet therapy. Do not tell yourself that this is just ischemic AF. He doesn't need oral anticoagulation because it is a temporary AF. No, there is some evidence suggesting that transient and self-terminating AF during STEMI may be a predictor of increased risk of embolic stroke during long-term follow-up, because this patient has a substrate in his atrium for the recurrence of atrial fibrillation. So this patient should start oral anticoagulation according to the CHA2DS2-VASc score. And now moving to a dangerous complication, which are the ventricular arrhythmias. The incidence of malignant arrhythmia, including VT and VF, has significantly declined, of course, in the primary PCI era, but still 6 to 8% of those with STEMI may develop hemodynamically significant VT or develop VF, resulting in sudden cardiac arrest. And the typical presentation of VT in those patients is being hemodynamically unstable, frequently to be polymorphic, as monomorphic VT is usually more common in scar-related VT in those with LV dysfunction. But in acute MI, usually it is polymorphic rather than monomorphic, relatively fast regarding the rate, and often degenerating into VF. There are some benign ventricular arrhythmias that you should be aware of in order not to be terrified or extensively use antiarrhythmic medications without any need. For example, Non-sustained VT persisting less than 30 seconds, it is the most common form of ventricular arrhythmia in the early phase of acute coronary syndrome, and so it does not require antiarrhythmics. Accelerated idioventricular rhythm, famously called IVAR, is a famous reperfusion arrhythmia that does not require any specific treatment. On the contrary, it is a good sign indicating successful reperfusion. And isolated PVCs are very frequent during the first day after reperfusion for STEMI, and so no specific treatment is needed. There is a famous comparison between early ventricular arrhythmias occurring in the first 48 hours after STEMI and late ventricular arrhythmias occurring more than 48 hours after STEMI. Regarding the early ventricular arrhythmias, so far their prognostic rule is controversial, as several studies suggested that patients with early VT or VF have increased 30-day mortality but no increase in the long-term arrhythmic risk. And in a prospective cohort study, patients with VF during the acute phase had similar incidence of late sudden cardiac death compared with VF-free patients during the 5-year observation. Whereas the late ventricular arrhythmias is different, as the long-term all-cause mortality after STEMI was predicted by ventricular arrhythmias occurring late after the period of electrical instability, which is the first 48 hours. As sustained VT or VF occurring during ongoing ischemia or late after reperfusion is associated with an increase in the long-term mortality, requiring an evaluation for ICD implantation or secondary prevention. We explained before on CardioMinds channel the guidelines of ventricular arrhythmias and prevention of sudden cardiac death released in 2022, and we explained in detail the issue of ventricular arrhythmias with coronary artery disease in Arabic and in English. And today, in the guidelines of acute coronary syndrome, we are focusing now on the specific recommendation for ventricular arrhythmias with acute coronary syndrome. For the acute treatment of polymorphic VT or VF, IV beta blockers or amiodarone have a class 1 recommendation unless contraindicated, as they reduce the incidence of malignant arrhythmia and the possibility of recurrence. Prompt and complete revascularization is the first-line treatment to treat the myocardial ischemia that is the precipitating factor for the ventricular arrhythmia, as urgent reperfusion here is very important in order to abolish the focus for recurrence of ventricular arrhythmias. Sometimes we may need transvenous catheter pacing for overdrive pacing if the VT cannot be controlled by repeated electrical cardioversion. But pay attention that the recurrence of VT or VF is common upon stopping the overdrive pacing. Sometimes we may need radiofrequency ablation at specialized ablation center followed by ICD in patients with recurrent VT, VF or electrical storm despite complete revascularization and optimal treatment. So in this patient, you arrange it for another coronary angiography and you found a patent stent and no electrolyte disorder. The patient is receiving antiarrhythmics, so he may have had Purkinje fiber injury. In this case, you are going to schedule for catheter ablation to abolish recurrent VT or VF. IV lidocaine may be essential as a class 2B if beta blockers, amiodarone and overdrive pacing are not effective or not applicable in case of recurrent VT with hemodynamic significance, and sometimes sedation or even general anesthesia is essential to reduce sympathetic drive, and we have discussed this in detail in the video of acute therapy of ventricular arrhythmias. The role of ICD is recommended as a primary prevention to reduce sudden cardiac death in patients with symptomatic heart failure, NYHA class 2 or 3, and LV ejection fraction less than or equal 35%, despite optimal medical therapy for 3 months or more and at least 6 weeks after MI, who are expected to survive for at least 1 year with good functional status. This is the same recommendation as in 2022 ESC Guidelines of Heart Failure, 2022 Guidelines for Ventricular Arrhythmias, and the current 2023 Guidelines for Acute Coronary Syndrome regarding primary prevention ICT implantation. We know that the first 40 days after MI, it is a class 3 to put an ICD for primary prevention, but there are some exceptions like incomplete revascularization, pre-existing LV dysfunction, occurrence of ventricular arrhythmias more than 48 hours after STEMI onset. In this case, it is a class 2B to put an ICD or to use a wearable cardioverter defibrillator. And the big no, the treatment of asymptomatic or hemodynamically irrelevant ventricular arrhythmias like the benign types that we discussed previously with antiarrhythmic drugs is not recommended, and the same as in the 2021 guidelines for heart failure, ICD implantation is not recommended within 40 days of MI, as here the implantation does not improve prognosis. Now let's move to the bradyarrhythmias, which are very common to occur, especially in those with inferior STEMI. In case of sinus bradycardia with hemodynamic intolerance or high degree AV block without stable escape rhythm, class 1s to start with the IV chronotropic medications like adrenaline, vasopressin, or atropine as a first-line treatment. If they fail, so temporary pacing is recommended in order to save this patient. And of course, the cure here is for urgent angiography with revascularization, as here I expect that the right coronary or the left circumflex, which is giving blood supply to the SA node or to the AV node, is causing this significant bradyarrhythmia like sinus node dysfunction or AV block respectively. So revascularization is essential to treat and terminate this bradyarrhythmia. When to consider a permanent pacemaker? If the high degree AV block persists after at least 5 days after MI, there is a class 1 recommendation to put a pacemaker, and this is the same recommendation as in the 2021 guidelines of cardiac pacing, as after 5 days persistent of AV block raises suspicion that it will not resolve due to permanent damage in the AV node, so a permanent pacemaker is essential. In patients with high degree AV block due to anterior wall MI, of course the high degree AV block is uncommon to occur after anterior wall MI, but sometimes there is extensive destruction in the His-Purkinje system. If this patient is having AV block and acute heart failure, here you may consider CRTD or CRTP in order to prevent the deterioration in LV function by the continuous RV pacing. And the big no, as we remember from the guidelines of cardiac pacing, that it is not recommended to put a permanent pacemaker if high degree AV block resolves after revascularization or spontaneously, still the same recommendation in the 2023 guidelines of acute coronary syndrome. Finally, we are going to speak about bleeding events that is very common to occur in those with acute coronary syndrome. Of course, we all know the bleeding is associated with poor prognosis in acute coronary syndrome, mostly if it is an intracranial hemorrhage, which may result in conization of brain and respiratory arrest, or massive hemorrhage resulting in hypovolemic shock. In this case, they are life-threatening and so worsening the prognosis. But this is not the only mechanism. There are other mechanisms, for example, type 2 MI, which is a result of bleeding causing oxygen supply-demand mismatch to the myocardium, so worsening the infarction and the necrosis, unplanned discontinuation of the depth, and the interruption of other medication, because if a patient develops significant active bleeding, in this case you may stop the aspirin, the P2Y12 inhibitor, so you increase the risk of stent thrombosis and you impair the revascularization, and you may stop other medications like beta blockers or ACE inhibitor to avoid any drop in the blood pressure. Sometimes the blood transfusion itself may increase risk of systemic inflammation, so it may result in increased morbidity and mortality. So we are going to explain these problems. Let's discuss some situations. For example, a patient developed bleeding on antiplatelets. So far there are limited treatment options, but platelet transfusion has been used extensively to improve platelet function in this situation. For example, aspirin-inhibited platelet aggregation can be restored after transfusing 2 to 5 units of platelets. Stopping the offending antiplatelet, of course, would be essential in this case. For example, prasugrel or clopidogrel treated patients may need 4 to 6 hours after the last dose to restore platelet function, and in case of ticagrelor, it may take more than 24 hours to restore platelet function and hemostatic competence. Don't be confused regarding these numbers because we still have the same duration to stop the P2Y12 inhibitor before surgery, which are 5 days for clopidogrel, 7 days for prasugrel, and 3 to 5 days for ticagrelor. But here we are speaking about bleeding event in a patient taking antiplatelets and when the platelet function restore its competency. What about if the patient developed bleeding on anticoagulants? If the patient is taking vitamin K antagonists, so the risk of bleeding of course increase if the INR exceeds 4.5. Vitamin K1 here is essential as 4 trials compared vitamin K with placebo in those with INR between 4.5 to 10 in the absence of ongoing bleeding, showing benefit regarding the reversing supratherapeutic INRs more rapidly but without evidence of benefit for the clinical outcomes. It can be used also in case of INR more than 10 due to the significantly higher risk for bleeding. Prothrombin complex concentrate is an important antidote in case of warfarin overdose or using the fresh frozen plasma or sometimes the recombinant activated factor 7, which is an important clotting factor in stimulating the coagulation cascade, because in case of presence of major or life-threatening bleeding on a VKA, they should be combined with vitamin K1. Sometimes prothrombin complex concentrate may show superior benefit to vitamin K1, but we still common antidote to use vitamin K1 beside prothrombin complex concentrate or the fresh frozen plasma. If the patient is taking the Bigatran, after stopping the NWACs, the improvement in hemostasis is expected within 12 to 24 hours unless the patient have impaired kidney function. Idarucizumab is a specific antidote for the Bigatran, which is a monoclonal antibody as a first line, which reverses its effect in a dose of 5 gram IV in those with uncontrolled bleeding or requiring urgent surgery. Prothrombin complex concentrate or the activated form, which have added activated factor 7, is essential as a second line if idarucizumab is not available. Fresh frozen plasma may be used if the first 2 lines are not available to counteract the drug effect or to be administered for those with major or life-threatening bleeding with dilutional coagulopathy. If the patient is taking factor 10 inhibitor like apixaban, edoxapan or rivaroxaban, the same principle. After stopping NWACs, the improvement in hemostasis is expected within 12 to 24 hours unless the patient has impaired kidney function. Prothrombin complex concentrate or the activated form is still the first line treatment in those patients, but we have also a specific antidote which is andexanet alpha, which act as a decoy receptor, so reversing the action of factor 10 inhibitors in those with acute major bleeding at a dose of 400 mg bolus followed by 480 mg infusion over 2 hours, as it significantly reduces the anti-factor 10 activity. Some bleeding events may be related to PCI as peri-procedural, which are associated with 5-fold increase in 30-day mortality, and the access site bleeding complication like from the radial puncture or the femoral puncture comprise 40 to 60% of peri-procedural bleeds. The Matrix trial showed that there is a significant reduction in major bleeding and all-cause mortality in those having radial approach compared with femoral approach for cardiac catheterization. That's why radial approach is a preferred vascular access for coronary angiography. And the ISAR-CLOSURE trial showed that the vascular closure device are non-inferior to manual compression regarding the vascular access site complications and reducing time to hemostasis. But in case of intensified antithrombotic therapy, their use was not associated with reduction in bleeding complications. That's why they are not routinely recommended. Bleeding events are very frequent during CABG, especially in those with non-ST elevation acute coronary syndrome, especially if the patient did not have enough time between stopping the DAPT and the surgery, and so they increase the morbidity and mortality. And there are several CABG-associated bleeds in patients on DAPT that should be managed using platelet concentrate if the patient did not stop the antiplatelets enough before surgery, and recombinant factor 7 that can be used for rescue therapy in those with uncontrolled bleeding if other correctable causes have been managed like hypothermia or coagulation factor deficiency, but putting in consideration that using These treatment measures may increase the risk of graft thrombosis, especially the saphenous venous graft, so they should be used cautiously. And finally, the issue of blood transfusion. The need for blood transfusion is associated with fourfold increase in early mortality and threefold increase in death or MI in acute coronary syndrome patients. We may think that yes, it makes sense because this patient is having ongoing bleeding. That's why the need for blood transfusion indicates worse prognosis. But sometimes the blood transfusion itself worsens the prognosis. So far, the nadir hemoglobin cutoff point regarding transfusion is not standardized and is variable across hospitals. But there are two famous strategies for blood transfusion. Either liberal blood transfusion, in which the blood is transfused if hemoglobin is less than 9 grams, or restrictive blood transfusion, in which the transfusion is only done if hemoglobin is less than 7 grams. There is a meta-analysis of 10 studies, including acute coronary syndrome patients, that reported that blood transfusion or liberal transfusion strategy was associated with increased risk of all-cause mortality compared with no blood transfusion or restrictive transfusion strategy. This may be strange, but sometimes the blood transfusion may increase systemic inflammation or reactions regarding the lung, for example, that worsens the prognosis and increasing mortality. The CRUSADE initiative study, including 44,242 patients with non-ST elevation acute coronary syndrome regarding blood transfusion, and it showed that if the hematocrit was less than 24%, transfusion reduced in-hospital mortality compared to no transfusion. If hematocrit between 25 and 30%, it had neutral effect, no benefit, no risk. If hematocrit was more than 30%, blood transfusion increased the mortality significantly. This means that blood transfusion should not be used liberally. We need to determine a hemoglobin level and hematocrit level and the clinical status of the patient to decide whether this patient will benefit from blood transfusion or not. So we have reached the end of our video today, and so our take-home message that an initially stable acute coronary syndrome is prone to variable complications ranging from small insignificant complication to devastating clinical impact. That's why those patients should be monitored for at least 48 hours to exclude occurrence of any clinically significant complication, and if they occurred, they should be managed appropriately. Thank you very much for watching this video, and wait next week for another video in the guidelines of acute coronary syndrome.